Afternoon all. As we are currently celebrating 75 years of independence, and WHO also celebrated its 75th anniversary on 7th April of this year, and our admission criteria for pro-emergency is 75 years. So we are inspired from that, and we are going to present today our CGR, and our topic is exploring the unexplored India at the rate 75. Why this age group? Because this age group is the fastest growing population, and it is supposed to be rise by 340% from 2011 to 2050. And we are trying to generate some evidence through our thesis and our research project. And our department is one of the youngest department in our institute, and so our today presenter is also too young. So now I want to call Dr. Abhijit to present his first. Yes.
Thank you, sir. Good afternoon to everyone. I'm Dr. Abhijit, a senior resident in the department. So we all know that the proportion of older adults, that is age 60 years and above, is exponentially increasing worldwide as well as in India. And India might be one of the fastest growing aging country. And in the year 2011, nearly 2% of the total population was aged 75 years and above. And by 2013, the life expectancy at the age of 70 was 11.6 years. And it is predicted that by the year 2050, nearly 5.2% of the total population will be aged 75 years and above. And this is a 340% increase from 2011 to 2050. So what does this mean to the healthcare professionals as well as aging senior citizens? So older adults, unlike their younger counterparts, are quite different in that there is the increased prevalence of multimorbidity. Multimorbidity is the presence of two or more comorbidities, and it is found that nearly 75% of the people who are aged 75 to 84 have multimorbidity, and the prevalence increases to nearly 81% after the age of 85 years. And it is also found that the number of comorbidities increases with the increasing age. In India, when diagnosed comorbidities were assessed, it was found that the prevalence of multimorbidity is nearly 24% in those who are 75 years and above. In addition to just mere presence of multiple comorbidities, there are other factors which play an important role in quality of life of the individual as well as life expectancy. One of them is called as geriatric syndrome. Geriatric syndromes are distinct conditions which occur due to the accumulation of impairments across multiple systems, and they affect multiple domains of older adults, especially functional abilities. There are quite a few geriatric syndromes. Few of them are cognitive impairment, depression, falls, frailty, and sarcopenia. In a study in France, which included people who are 75 years and above, they found that nearly 80% of the individuals had at least one geriatric syndrome, and the most common of them was presence of polypharmacy, which was followed by falls. In India, in people who are 70 years and above, it was seen that nearly 76% of people had at least presence of one geriatric syndrome. So in addition to these, there are also other issues which an older adult faces, such as financial burdens, psychological well-being, and social support. So how exactly is a person supposed to detect these vulnerabilities in an older adult? The answer would be to perform a comprehensive geriatric assessment. So here we see that biological aging is heterogeneous across individuals. That is, even though the chronological age increases at a fixed rate, we see that the phenotypic age is very broad, and this gap increases after the sixth decade of life. So CGA is one method to identify these vulnerabilities, as defined by Larry Rubinstein. It is a multidimensional interdisciplinary diagnostic process to determine frail older people's medical, psychological, and functional ability, to develop a coordinated and integrated plan for treatment and long-term follow-up. So though it says comprehensive geriatric assessment, the process does not end at just evaluating and assessing vulnerabilities. It also encompasses multidisciplinary team which will make a structured, directed plan for that older individual, which will take into consideration the older person's wishes as well as goals in life. So the major 4 domains of a comprehensive geriatric assessment include physical health, which includes the traditional history taking, physical examination, indicators or lab data, and disease specific severity indicators. In addition to this, it also encompasses functional status, which includes basic and instrumental activities of daily living, mobility issues, risk of fall. It also includes psychological health, which has cognitive and affective status, and socio-environmental status of the older person. To quote one study which looked at the benefit of doing a CGA among patients who are 75 years and above who are attending emergency services, they found that impairments in various domains were predictive of 3-month as well as 6 months mortality. At 3 months, presence of malnutrition, presence of urinary incontinence, and multimorbidity was independently predictive, and at 6 months, presence of malnutrition, multimorbidity, and impairment in activities of daily living were predictive of 6 months mortality. In the recent years, we see there is enthusiastic and exponential increase in the research output, focusing on people who are 75 years and above, right from trying to understand how to manage triple vessel disease in them, how to manage hypertension, finding their goals, trying to figure out their normative data. So our department is also not behind. We also have done a couple of studies which are focused rather on patients who are 75 years and above, and we'll be going through them right from trying to identify the predictors of survival among acutely ill old patients, trying to describe their cardiovascular profile and their gait parameters, and also we'll try to see if cognitive impairment is an inevitable aging change, or are there a group of individuals who can even outperform younger adults in cognitive abilities. And now I would like to call upon Dr. Akshata to continue the presentation. Thank you.
A very good afternoon, everybody. I'm here to present the acute illness and the outcomes in the 75 plus population. So as we have seen, oldest old are the population aged 85 years and above. Hospitalization are common among the elderly, especially in this population. Various studies have been done, and common causes for this acute hospitalization have been observed as infections, arrhythmias, fall, ischemic events, diabetic complications, acute respiratory failure due to congestive heart failure, acute exacerbation of COPD, and GI. So acute illness is a major stressful event for any age group. Especially in elderly, it can make them vulnerable to potentially dangerous outcomes. Aging, as you all know, it includes a lot of cellular changes which leads to homeostenotic dysregulation, and which leads on to tissue level dysregulation, following which there is development of various geriatric syndromes. And presence of these geriatric syndromes leads to atypical presentation of the common illnesses and significant deterioration in the functional ability, which will further predict the recovery rate, morbidity, and mortality. Even though there are a lot of accumulation of the deficits with aging, there can be factors which help in predicting survival even in the oldest old. There have been a lot of studies, especially in the outpatient department or the long-term care facilities for predictors of survival. There are very few studies which focuses on acute illness and predictors of survival. So some of the factors which have been studied are nutritional status, delirium, cognitive impairment, activities of daily living before the onset of the acute illness, sedentary lifestyle, renal dysfunction, and some of the biochemical parameters which have been studied are sirtuins, CRP, and activin A and myostatin. So a brief note on what exactly are sirtuins and sestrins. These are biological regulators in many of the cellular process, and they maintain the genomic stability and stress response. Among the sirtuins, especially 1, 2, 1, 3, and 5 are needed for the glucose homeostasis and for the elimination of reactive oxygen species, and to control various metabolic reactions like decarboxylation, desuccylation, etc. And cestrins are stress-induced molecules which reduce the reactive oxygen species accumulation and induce autophagy. And these have been implicated in the acute illness, and we are studying this as a predictor of survival. So our study was to see whether survival in a stressful situation of acute hospital care is just a stochastic process of collection of random variables, or if there are any determinants of survival in the oldest old patients. So we assessed the spectrum of health in the oldest old, and we examined the association of the health parameters, clinical and social factors with in-hospital and 1 month survival. And we also quantified the differential expressions of the proteins which I said, that are sirtuins and cestrins, to see the relationship with the survival. So our primary objective was to determine the factors associated with in-hospital survival in patients above 85 years of age admitted with acute illness. Secondary objective was to see factors associated with 1 month of survival and to see if the serum markers were associated with in-hospital and 1 month survival. So this was a hospital-based prospective observational study, and an independent multidisciplinary team consisting of geriatrician, nursing staff, physiotherapists and dietitians managed the admitted patients, and the outcome was recorded either as discharged after improvement or discharged to a long-term care or to a hospital death. So all the patients who were above 85 years of age were included, except for the patients who withdrew their consent or died within 1 month, 21 day or 24 hours of hospitalization, or if there was history of previous admission within 1 month, and patients on mechanical ventilation on admission. So once the patients were included in the study, they underwent a detailed demographic assessment, including age, their comorbidity details, and following that, detailed geriatric assessments. As we have seen, geriatric syndrome is associated with outcomes of post-hospitalization following acute illness or even long-term. So we did a geriatric detailed assessment. Following that, biochemical analysis with sirtuin and cestrin. So the survivors were telephonically reassessed 4 weeks after discharge. They were inquired regarding their functional status, rehospitalization and death. And the caregivers were asked about the cause of death if there was any event. So this is the baseline characteristic of the participants, and mean age of the study participants were around 88 to 89, and the comorbidities were comparable among both the survivors as well as the non-survivors except for diabetes. And these are the physiological and lab parameters in which Apache 3, respiratory rate and total leukocyte count were significant among the survivors and non-survivors. And these are the geriatric syndromes which we assessed. One was delirium and ADL before the onset of illness and after admission, mini nutritional scale for nutrition assessment, and geriatric depression scale for depression assessment, and Morse fall scale for fall assessment, and Rockwood scale for frailty assessment. And this is a forest plot representing association between the variables and in-hospital outcome. This is a univariate analysis in which diabetes, higher Apache 3 score, and delirium and sirtuin 1 and 5 were significant. We went ahead with the multivariate analysis in which diabetes, respiratory rate, delirium and sirtuin 5 were significant. And this is the bar graph showing the sirtuin and the cestrin levels, and there was significant difference in the sirtuin 1 and 5 levels among the survivors and the non-survivors. So this is the outcome at 1 month post discharge. So this is with the telephonic follow-up. So this is the forest plot representing the univariate analysis in which again Apache 3 higher score and respiratory rate, delirium and Rockwood score was positive, and in multivariate analysis diabetes and delirium were the only significant parameters which were predicting the survival. So as you can see, there occurred 11 events during the hospital, and 84.3% of the oldest old who presented with the acute illness survived, and the higher Apache score, tachypnea, diabetes, delirium, and sirtuin 1 and 5 predicted the survival in univariate analysis, whereas diabetes, tachypnea, delirium, and sirtuin 5 predicted the survival after multivariate analysis. Even at 1 month post acute illness, you can see that 74.3% survived, that is 52 patients were alive post acute illness, and diabetes and delirium were again the predicting factors. So as you can see, chronological and biological age are different. Just because the patient is older and having a significant stressful event need not end up in a poor outcome. There can be significant amount of survival as well. So in our study, the most common cause for hospitalization was infectious disease, respiratory and the urinary tract infection, and delirium, tachypnea, diabetes were the predictors of in-hospital survival. Diabetes and delirium were the predictors of 1 month survival, and sirtuin 5 is a good biochemical marker to predict in-hospital survival. Now I would like to call upon Dr. Pramod Kumar sir, Assistant Professor Geriatric Medicine, to discuss regarding cardiovascular aging.
Thank you, Dr. Akshata, and good afternoon to all of you. So in this session, we'll be discussing about the cardiovascular changes with aging and its clinical implication. So as we know, there are multiple age-related changes that occur with in the cardiovascular system. In the vasculature, it includes increased arterial wall thickness and stiffness, which results in a increased systolic BP and a wide pulse pressure. This decreased responsiveness to vasoactive substance and other endothelial dysfunction, which results in an increased risk of atherosclerosis. In the heart, there is again increased left ventricle thickness and stiffness because of collagen and fibrotic deposition. There is impaired diastolic relaxation. There's calcific and fibrotic degeneration of the valves. There's loss of nodal tissue and fibrosis of the conduction system. This results in a decline in the resting heart rate, and heart rate variability also decreases. And there's a decrease in the peak cardiac output and ejection fraction. So all these changes result in multiple clinical consequences in the older adults, which include hypertension, increased risk of hypertension, decreased exercise capacity because of the decreased peak cardiac output, atherosclerotic changes resulting in increased risk of CAD and stroke. There's an increased risk of arrhythmias, and also the increased risk of heart failure, both systolic heart failure and diastolic heart failure. So this is the data from the American Heart Association, which shows that there is a gradual increase in the prevalence of cardiovascular diseases with age. In the 60 to 79 age group, we can see that the prevalence of CVD is 75% around, which increases to 90% in the age group 80 plus. So older adults age 80 and above, 9 out of 10 patients would have CVD. Also, there is a huge burden of death that are attributable to the CVD. And as we all know, cardiovascular death are the most common cause of death worldwide and in India as well. So as far as data in India is concerned, this is the chart showing there's an increased prevalence of CVD in India as well, but there's no age-specific data that is available. So in our department, we conducted this study in which we assessed 200 older patients from our OPD who were age 75 and above, and using non-invasive tool, we assessed them for cardiovascular diseases and the risk factors. So these are the results. Among the risk factors, we found that there was a high prevalence of cardiovascular risk factor. Obesity, sedentary lifestyle, and smoking were present in about 30% of the population. Hypertension was present in 60% of the population. A quarter of them had diabetes, 40% had dyslipidemia, and the most common risk factor that was present in our population was hyperhomocystinemia, which was found to be present in 83% of the population. These are the echocardiographic findings, and here we can see that some form of valvular dysfunction was present in about 33% of the population, whereas 6.5% had moderate to severe valvular dysfunction. As far as the left ventricle structural changes are concerned, concentric hypertrophy was present in 50%, global hypokinesia in 4%, and 2.5% had regional valve motion abnormality, and one of the patient had HOCM. The left ventricle ejection fraction, 4.5% of the population had decreased left ventricle ejection fraction, 41 to 50%, and 5.5% had ejection fraction less than 40%. The most common finding in our echocardiographic finding in this population was left ventricle diastolic dysfunction. It was present in about 81% of the population. 75% had grade 1, 5% had grade 2, and 1% had grade 3 to grade 4 diastolic dysfunction. So as we know that left ventricle diastolic dysfunction and heart failure with preserved ejection fraction, they have gained clinical importance over the past few decades. It has been found that LVDD has increased prevalence with age. It increases with comorbidities like hypertension, obesity, and diabetes, and it is also a predictor of mortality. As we can see in this study, that in patients with diastolic dysfunction and a normal systolic function, it was on a follow-up of 6.2 years, it was found that moderate diastolic dysfunction and severe diastolic dysfunction has an increased risk of mortality. And further, in our study, we found that overall, the prevalence of CVD was around 76%, which was 80% among the female and 74% in the male patients. Among the CVD, 17.5% had coronary artery disease, 10.5% had heart failure, and 5.5% had a history of stroke. So, since the population had an increased prevalence of CVD, we also assess them for geriatric syndrome. So, there's more and more opinion that now that geriatric syndrome despite having a contributing role in CVD patients, they are often under-recognized and overlooked. So, this is a recent study published in the Journal of American Heart Association, which shows that geriatric syndrome like delirium, dementia, depression, fall, pressure ulcer, and others, they have a increased prevalence among those patients with CVD as compared to the general population age 65 and above. And also, they are increasingly more present among those patients who are admitted in hospital in acute care. Frailty, another geriatric syndrome. It has been seen that CVD such as heart failure, CAD, atrial fibrillation, and stroke are all associated with a high risk of frailty. There are multiple pathophysiological theories that have been proposed. For example, a heightened inflammatory state, decreased physical activity and physical deconditioning that occur in patients with CVD. And the most widely accepted theory is the cumulative burden of risk factors. So in this diagram, we can see that both cardiovascular diseases and frailty have common risk factors like obesity, smoking, poor diet, lack of exercise, and comorbidities. And the interplay between these risk factors, CVD and frailty, results in increased disability and increased mortality. So in our study, we also pursued to find the association between the geriatric syndrome and CVD. We assessed geriatric syndrome using the comprehensive geriatric assessment, in which we assessed for fall, incontinence, pain, anorexia, polypharmacy, and multimorbidity. And we also assessed basic activities of daily living, instrumental activities, cognition, depression, and frailty. So it was seen that there was a high prevalence of geriatric syndrome. As you can see, polypharmacy was present in 50% of the population. So the 50% older adults, age 75 and above, coming to our OPD, were taking more than 5 or more drugs, and 90% had multimorbidity. Then a major proportion of them had impairment of their basic and instrumental activities, and frailty was present in 30% of the population. We also found the association between, we also sought to find the association between CVD and geriatric syndrome, and after multivariate regression analysis, it was seen that multimorbidity, polypharmacy, and frailty, all three had significant association with CVD. So we have all seen the importance of CGA in older adults. Similarly, in patients with CVD, there is an increased role of CGA. It has been, it can be used to establish an integrated and coordinated treatment plan for older patients with CVD. It is proposed that CGA can be used both in acute and chronic care patient. In acute care, patients admitted with heart failure or MI, they can have CGA can be used to determine the role of intervention, especially the invasive interventions, and also for care planning before discharge. In chronic patients also, regular CGA can be used to optimize their treatment. There are more and more evidence now suggesting that CGA has a role in prognostic role and in planning their treatment in patients with CVD, like in heart failure patients and acute coronary coronary syndrome patient and in cardiovascular disease patients overall. So in this study, we see that patients with CVD, they had more prevalence of geriatric syndrome, multimorbidity, polypharmacy, and frailty, and also they were associated with clinical and prognostic marker implication, like there was decreased functional status and quality of life in these patients, and also they were associated with increased hospital admission and mortality. So to conclude, we found that older adults age 75 and above have a high prevalence of CVD and the risk factors. CVD in these patients have commonly associated with geriatric syndrome, which also have prognostic significance. And CGA in this CVD patient can help in better decision making and care planning for these patients. So now I call upon Dr. Sudeep and Ruchika to present their presentation on mobility profile of older adults.
Thank you, sir. Now we will discuss about the mobility profile of older adults. As you all know, the gait deteriorates with age. Gait and balance disorders are among the most common cause of falls in older adults and often lead to injury, disability, loss of independence, and limitations in quality of life. After the age of 70, gait and balance impairment can increase by as much as 35%. A study published from our department has shown that with increase in age, there is decline in the gait speed. Mobility being one of the pillars of AIIMS of geriatrics, gait assessment will become very important for the geriatrician. There are two types of gait analysis. One is qualitative, the other one is quantitative. Qualitative include visual observation, video observation, scales and questionnaires. And quantitative, which involves kinematic analysis, kinetic analysis, and EMG analysis. Our main focus for today will be on the kinetic analysis. The kinetic gait analysis and assessment systems provide measurable and repeatable data on gait impairments. This allows geriatrician to measure gait precisely when first evaluating a patient and to measure the progress in walking, balance and coordination as the intervention progresses. When compared against a baseline measurement taken pre-intervention, this data can help verify efficacy of the intervention and determine when the effect of intervention has plateaued. So what we did, we focused on spatiotemporal gait analysis in older Indian adults using ZENO WALKWAY and its association with geriatric syndromes. It is one of the first studies to assess the gait parameters of Indian health-seeking older adults above 75 years using protokinetics. So our primary objective was to analyze the gait in persons aged 75 years and above, and secondary objective was to find the association of various gait parameters with different geriatric syndromes. We conducted a cross-sectional observational study at the outpatient services of geriatric medicine, including older adults aged 75 years and above, having informed consent and ability to undergo detailed gait evaluation process. We excluded participants who were having acute knee pain using visual analog score rating of more than 7, critically ill patients, and severely cognitive impaired patients. The subjects underwent a detailed assessment which included demographic details and anthropometric measurements, comprehensive geriatric assessment including assessment for the presence of common geriatric syndromes using predefined questionnaire. The ZENO WALKWAY gait analysis system was used for gait assessment that provided with different important parameters of gait.
Now talking about the ZENO WALKWAY, it is basically a walkway with a floor mat which has got embedded sensors in it. The patient is made to walk on the floor mat which collects pressure from the sole of the foot. The data is then fed into the computer and the PKMR software analyzes the various spatiotemporal gait parameters. Now talking about the gait cycle, it comprises of the stance phase which makes up approximately 60% of the gait cycle and swing phase which comprises about 40% of the gait cycle. The stance phase further consists of double limb support, single limb support, and again a double limb support. Now talking about the stance phase, it begins with the heel contact, that is the initial contact, followed by foot flat, which is the loading response where the initial contact of the forefoot is with the ground. Then is the mid stance where the greater trochanter is in alignment with the vertical border of the foot. Followed by heel off, that is the terminal stance, and toe off, which is the pre-swing. The swing phase, it begins with acceleration, that is called the initial swing, followed by mid-swing where the swinging limb overtakes the limb in stance, and lastly the deceleration, which is the terminal swing. Now talking about the various spatiotemporal gait parameters, to begin with step length, it is basically the distance between the point of initial contact of one foot and the point of initial contact of the opposite foot. That is from the left foot to the right foot or from the right foot to the left foot. The stride length is the distance between successive points of the initial contact of the same foot. That is from left to left or right to right. The stride velocity is measured as the ratio of stride length to stride time. The stride width is measured as the perpendicular distance from the heel of one foot to the line connecting two consecutive heel strides of the contralateral foot. That will be from the initial contact of left foot perpendicular line coming from right heel stride to right heel stride. The stance percent of the gait is described as the phase of the gait cycle from touch down to lift of the same foot. The swing percent of the gait cycle is the phase of the gait cycle during which the foot of interest is not touching the ground at all. Talking about the total double support percent is when both the feet are simultaneously contacting the ground. The velocity is measured as centimeter per second and is calculated as distance walked per unit time, and cadence is calculated as number of steps taken per unit time.
Thank you, ma'am. Coming back to the study, the baseline characteristics of the population was obtained. The mean age of population was 78.56, which included 66 patients of age 75 to 79 years, 27 were from age 80 to 84, and 7 were from more than 85 years of age. And it included males 85%, which was predominant. Hypertension was a major comorbidity which accounted for 62%, followed by diabetes mellitus, BPH, and CAD. We did geriatric assessment using comprehensive geriatric assessment for the study population. 40% of the population were having polypharmacy, 34% were frail, ADLs were impaired for 25%, and IADLs were impaired for 22%. Nutritional status was abnormal for 33%, and 6% were cognitively declined, and 57% were depressed. The gait parameters were obtained from the ZENO walkway. It is accordingly as mean of step length was 46.12 centimeter, stride velocity was 76, stride width was 13 centimeter, stance percentage was 64, swing percentage was 35, velocity was 75 centimeter per second, and cadence was 97, and total double support was 29. We further try to find the association of step length with various geriatric syndromes. After the analysis, we found out that there is a negative association between the step length and basic activities of daily living, IADL, mini nutritional status assessment, HMSE, and increased score on geriatric depression and frailty. Similar observation was obtained for association of velocity with various geriatric syndromes. So coming to the discussion, there is a significant association between the various gait parameters and geriatric syndromes. The mean value of gait velocity was 75 centimeter per second. We compared this with the normative spatiotemporal gait parameters from the US population and found out that the mean gait speed of US population was 110 centimeter per second. So clearly there is a difference in the main gait speed of Indian population and the US population. So what is the implication of our findings? So there is an importance to define the cutoff for our population. As we all know that gait speed is used in the definition of sarcopenia and frailty. Different working groups have given different cutoff for different population for Asian, American, and European. But if we include those criteria, by those definition, more than 50% of our population will become sarcopenic. So there is a need to define our own cutoff for our population. Secondly, gait impairment is one of the underdiagnosed condition, and it has significant correlation with some geriatric syndromes, thus implying early care regarding gait and fall in those persons. Now I call upon Dr. Deepa Anil Kumar to talk about super ages.
Thank you, Dr. Sudhi. Do you believe the cognitive impairment is inevitable with aging? Our study suggests the answer is no. A very good afternoon to one and all present here. Today, I am here to present the findings of our research project titled Characterization of Indian Superages, a pilot cross-sectional study. To begin with, let's see who are superages. Superages are individuals aged 80 years and above who exhibit cognitive abilities equivalent to those individuals who are about 3 decades younger than them. Previous studies on superages had been conducted on Western population, and there is a paucity of data in Indian context. This prompted us to conduct a study on superages by characterizing them based on the performance in neuropsychological assessments, radiological imaging, and blood biomarker profile. The study was first of its kind in Asia, and it was funded by the Indian Council of Medical Research. The major objectives of our study were to characterize superages among older Indians using psychological tools, blood biomarkers, and functional MRI, and to develop a socio-culturally adapted screening tool to assess superages. It was a pilot cross-sectional study conducted in the Department of Geriatric Medicine for a duration of 3 years starting from 2019 to 2022. Before recruiting the participant into a study, we had a well-defined inclusion-exclusion criteria. Although the definition of superages suggests the age cutoff is 80 plus, in 2018, Borelli et al. Proposed age cutoff of superages in developing country to be 75, considering the difference in the life expectancy and the definition of older adults in developing and developed countries. So keeping this in mind, we recruited older adults aged 75 years and above who were graduates and were proficient in English, and they also had to score 0 in the clinical dementia rating scale. We also recruited individuals aged between 25 and 50 years who were graduates and were proficient in English. Individuals with dementia, mild cognitive impairment, those who having visual and auditory limitations and having the diagnosis of a major neuropsychiatric disorder, and those who refused to give consent were excluded from the study. Based on this inclusion-exclusion criteria, we have recruited 55 older adults and 50 young adults, and they underwent a neuropsychological assessment by a trained psychologist using Ray Auditory Verbal Learning Test, Boston Naming Test, Color Trail Test, WAIS-4, and NEUROPSYCHOLOGICAL. Lifetime diet patterns of the participants were assessed using a food frequency questionnaire which was indigenously developed by the Department of Dietetics at AIIMS, New Delhi. Details on physical activity was also noted. Based on the scores of delayed recall domain in RAVLT and IQ as assessed by WAIS-4, older adults were further classified into superages and typical older adults. Consenting individuals from each group were then subjected to structural and functional MRI, and they were also tested for blood biomarkers. As I mentioned previously, the neuropsychological assessment was conducted using the following tests: Ray Auditory Verbal Learning Test to assess the episodic memory, Boston Naming Test to assess the semantic memory, Color Trail Test to assess sustained attention, WAIS-4 to assess intelligence quotient. Personality profile of the study participant was assessed using NEUROPSYCHOLOGICAL. Serum concentration of ApoE4, SIRTUIN1 and FOXO3A was conducted using surface plasmon resonance technology in a BioCore 3000 system. MRI acquisition was carried out in a 3 Tesla MRI scanner using 48 channel head coil. The consenting participants fulfilling the inclusion criteria for MRI testing, which included 9 superages, 4 typical older adults, and 8 younger participants, they underwent high resolution T1 weighted structural brain imaging which lasted for 10 minutes and a cognitive task-based functional MRI which lasted for 8 minutes. The stimuli during functional MRI were given in the form of audio files, and during the image acquisition, the MR signals in the audio stimuli from software were synchronized, and the participant responded to the stimuli via headphones. The figure depicts the block design paradigm of functional MRI during encoding and retrieval task. Coming to the results, out of 55 older adults, we had 40 males and 15 female participants. As I mentioned before, older adults were further classified into super ages and typical older adults based on the score obtained in the delayed recall domain of RAVLT and IQ as assessed by WAIS-4. To be designated as a super ager, an older adult had to score greater than or equal to 9 in the delayed recall domain of RAVLT and greater than or equal to 110 in the IQ assessed by WAIS-4. Based on this criteria, we had 24 super ages and 31 typical older adults in our study. As far as the younger group is concerned, we had 26 males and 24 female participants. The mean ages in super ages, typical older adult and YP group were 78.9, 77.6 and 34.5 years respectively. As shown in the table, a statistically significant difference was observed in the test score among the groups. The post hoc analysis revealed that the super ages outperformed typical older adults in all the cognitive domains, and they even outperformed the younger participants in BNT and WAIS-4. Coming to the personality domains, there was a statistically significant difference in neuroticism and agreeableness among the group, and although post hoc analysis revealed that the difference was significant between younger participants and super ager group, where super agers had a better performance. As suggested in the table, we observed a statistically significant difference in APOE concentration among the groups, and post hoc analysis revealed that the significance was different in between younger participants and super agers, where super agers had a lesser serum concentration. In case of FOXO3A and sirtuin-1, younger participant had the highest serum concentration, followed by super agers and then typical older adults. Brain activity during encoding was found to be the highest in super agers, followed by younger participants and then typical older adults. The brain activity during the retrieval task of functional MRI also revealed that super agers had the highest performance, followed by younger participants and typical older adults in anterior cingulate cortex, frontal region, DMN and hippocampal areas. Lifetime diet patterns of super agers and typical older adults were mostly similar. However, a statistically significant difference was observed in the total energy and in the consumption of food containing protein, zinc, total dietary fiber, total fat, carbohydrate, cholesterol and amino acid for the period above 60 years of age. The majority of participants in the super ager group and TOA group were engaged in regular physical activity. However, the mean duration was greater in super ager group than in the typical older adult groups. Our study can be summarized as super agers outperformed typical older adults in episodic memory, working memory and processing speed. They also showed greater brain activity than typical older adults during the encoding and retrieval task of functional MRI. Super agers had a lower serum concentration of APOE4 and a higher concentration of FOXO3A than typical older adults, though the difference was not statistically significant. Now I would like to request Dr. Nidhi to present the conclusions of the session.
Thank you, Deepa. A good afternoon, everyone. So, just some brief points regarding, we just take a small glimpse into all the studies which we presented. So, 75 plus is the fastest growing population. And it is very important to do a comprehensive geriatric assessment in this age group due to the high prevalence of geriatric syndromes, which has important prognostic implications. And the aging process is universal, but it is not uniform. It is not same for everyone. And the physicians, they tend to have a pessimistic attitude when it comes to the treatment of older population. It has been seen that there are certain parameters helps us in making the better decision making and making a proper deciding the proper care plan for them. Now, if we
And it has been seen that if we do a comprehensive, detailed quantitative gait assessment, it has been shown to have an important role to predict the geriatric syndromes, which again has important prognostic implications. So superagers, they have shown that successful cognitive aging is very much possible. So once you cross the age of 75 years, that doesn't mean that you cannot have a successful cognitive aging. You can have the better cognitive reserve by having a good diet, doing regular physical activity, improving your social interactions, and taking up the activities which challenges your brain. And by these activities, you can actually become a superager. Thank you. Oh, sorry. So let us all aspire to be superagers by doing all the activities, by taking proper diet, doing lot of physical exercises, and improving our social interactions. Thank you. So any question is being invited? Yeah.
Vascular disease, did you find any kinds of gender specific prevalence in cardiovascular disease in your presentation?
In our study, we found we found that the representation of male and female was different. Female constituted only 25%. As far as difference concerned, there was no significant difference in the gender specific cardiovascular diseases. Female had 80% and male had 74%, but there was no significant difference between them.
So my question is, do you think that there is, because according to the AHA 2019 report, females tend to have more CVD than males. So did you find something on this similar grounds in your study?
Not in our study, maybe it was not powered enough for that, but we did not find any difference in our study.
Female sample was lesser than males.
Yes, it has been seen that in hospital studies, in hospital-based study, in outpatient-based study, there is a significant difference in the representation of male and female in most study, from our department and from AIIMS other studies also. So in our study, it was female constituted 25% of the population.
Study that we have found from our department. So from the neuroscience perspective, that the test that you have used overall, since it's all for the graduates, they are highly educated people.
Yeah.
So how can you say that? Do you think that education is a protective factor for them? How can you say that the superagers are more protected if they are not educated?
No, we are not saying that education is a protective factor based on our study, because we had only selected participants who were graduates. But this was done because the neuropsychological assessment tools, especially WAIS, had a very difficult English words. So we had to recruit people who can understand the words and meaning of it.
Do you think that the superagers who are illiterate,
They can also,
think that they can also
Yeah, they can also-
overcome the typical older adults?
they can be.
They can
They can be, but then we'll have to have a proper data on that. Using socio-culturally adapted tool, we have to collect data.
Why not we have included the lower education people in our study? We can have those also, then we could have.
Yeah, we are planning
Whether
to.
education actually played a role or not. That could
Yeah,
have
we are planning to conduct a future study on that after we develop a questionnaire which is socio-culturally applicable in Indian population with all age group and with means all educate with all strata of educations. I just want to add one thing to this. As we were reading about the superagers, so in a recent study, like there have been a lot of theories regarding superagers. Like, so one of the very important theory was that even the environment has an influence, and the educational status that actually has a very important role. The people who were highly educated or who had the jobs which were really which has an impact on their mind, which really required them to
what do you call it? Yeah, intellectually who were involved, so they were found to be protected against this cognitive deterioration. And secondly, the social interactions. So yeah, I think education plays an important role. I'm not sure regarding whether the yeah, we don't have data. The studies are still going on, but this actually
We have to have a tool which will be applicable to our population in all educational sphere.
yeah.
Actually leads to a decline because higher education have people with the higher education are taking much more faster decline in population than those people who are less educated. So that's my question. Whether education is a protective factor or it is actually not a protective factor, even though typical older adults were educated, equivalent to that of super ages. No, we don't have a low education just because of the neuropsychological tools, which would be difficult for the illiterate people to understand. Previously, published reports use these tools, so we just followed that study and used these tools. Because we also had to have the cutoff based on those tools. We don't have a normative data on our population based on those tools.
Any other question? Thank you.